Welcome to the Allied Health Professionals podcast series
with your hosts, Jennifer Trafford
and Alison Kerr. Hello everyone and thanks for tuning in. Today we are in Redcar Primary Care Hospital with...
I'm Marie Redden. I'm an occupational therapist and I'm the stroke therapy lead here over at Redcar. So I manage the therapy staff on Zetland ward and our early support discharge team.
I'm Hannah Devereux. I'm a speech and language therapist. I manage the stroke speech therapy team across the pathway, which is Ward 34, the stroke unit there, Zetland ward and ESD.
So thank you for allowing us to come and interview you for the podcast. I'm really excited about hearing about the community element of what our therapy teams bring and how that affects not just our patients, but our acute settings as well.
I mean, we do play a vital role, don't we? Particularly in therapy. So obviously our background is stroke. So when people are admitted to hospital, quite often what keeps them in hospital for a prolonged period is the therapy needs. So quite often they're much more they're medically stable significant periods prior to being somewhat therapy fit for discharge. And it's the pathway that they follow with us therapists that facilitates the discharge into the community setting. And often for stroke patients, the acute stage and the hospital stay is such a short part of their journey and their recovery process that the community part of the therapy is as important as the inpatient stuff. We often find people make more recovery at home. It might be at a slower pace, but the recovery that they make can have such an impact on other services. So for example, someone might have less care because they've managed to be more independent with certain activities of daily living. So they might be able to get washed and dressed as a result of having therapy, which therefore means financially they don't need the care sector going in anymore. So I think...
I mean, from a speech and language point of view, we're looking at communication and the swallowing side of things. So equally, that can absolutely be supported in the community. That doesn't need to be, I mean, obviously we stabilise them in the acute stage, but I think often when we think of rehab, we think of mobility and being able to, do things, but obviously communication, if you have a communication difficulty after stroke, it can have a massive impact on not just only your ability to communicate, but maybe you're going to feel isolated, you're going to feel, lack of confidence, lack of self-esteem. So our part is working with patients to improve their communication, but also improving their confidence around their communication and being back home.
Actually, I think that's really relevant, the fact that you're talking about your patients, not just from a clinical point of view, but actually a holistic point of view. Because I don't suppose I thought about how much having somebody with a stroke affects not just their abilities, but their confidence, their family and home life.
Yeah, I mean, evidence shows that most people at some point following a stroke have changes to their mental health. So a lot of people go through stages of anxiety or depression. Sometimes that can be with family members as well, because everybody, I think for me, stroke's one of the only conditions where you don't know what you're going to recover to. So no one can ever tell you by 6 months you're going to be doing X, Y, and Z, and it's always the unknown, and that has such a detrimental effect on people, which in turn can affect their engagement in therapy. So if somebody lacks motivation because they're anxious or they're feeling a bit low in mood, it has such a negative impact. Nationally, there's a shortage on psychologists working within stroke services. So I think it's really important that as a team we're upskilled to be able to enable patients to feel that they're taking some lead and control in their therapy. We're very much goal orientated, so we could want somebody to be able to sit up for 5 minutes, for example, unaided, but actually what's more important to them is that they can sit in a wheelchair for an hour so that they can go for a cup of tea with their grandchildren or something. So part of our role is to sit with patients and look at what's meaningful to them, what do they want out of therapy, what's actually manageable and achievable for them, how can we support them to achieve that. And that's not just as a single profession, we do it as a team. So if it was somebody with a mobility issue, cognitive impairment, speech impairment, and they want to be able to go to a a cafe and have a cup of tea. What do we all need to do together to support the patient to achieve that? And we do work really holistically. I've never worked in an area where you do work as such a close knit MDT. I don't know if you would agree.
Yeah, so often, like Marie said, with the cognitive side of things, which obviously impacts language, sometimes it's hard to pick apart what is a language impairment and how much of it is cognition. So often, especially here at Redcar and out in ESD, speech and OT will do joint sessions. That also helps with sort of patient fatigue. So you've not got a speech therapist going in for an hour and then an OT going in for an hour, and actually the OT isn't getting as much out of the patient because they're exhausted. So actually doing the joint sessions, both tag teaming what the therapy and supporting them. And I think equally, if you think about these patients being at home, they're completely in control of when they get up, when they eat, when they go to the toilet. And when you're on an acute ward, that's dictated, isn't it? So and it's so not representative of real life. So getting them home, giving them some control back, just that is massive.
Yeah, that impact's massive, isn't it, on their life and their family's life, and getting that is so important. So when you're working in your MDT, obviously your AHPs, what other AHPs are you working with in that space?
So our team predominantly is speech therapy, physiotherapy, occupational therapy, dietetics. We've got therapy assistants. We do have some support from a psychologist. They work alongside our team to give us support where needed, signpost us to what we can do with patients. And then tertiary sectors, so like the Stroke Association, they're invaluable for some patients. They provide advice and support, signpost into other services such as financial support, which all impacts people's long-term recovery and engagement. And we've got administration support, consultant therapists. So we're really fortunate. We're one of nationally, there's a number of therapy consultants within stroke, and we're fortunate we've got one here. So our service is led by a stroke consultant, which is a therapist by background. And I think that's really positive on the patients, isn't it? Because their background's therapy, rehab, that's what we do. We want to enable people to be able to manage at home, get them off the wards as quick as we can. Once they're home, look what's meaningful to them, support them with their recovery going forward.
And I think also it works really well because we have the one consultant who we do the MDT with, and we're all on the same page for that patient. So obviously we get to know families, and we get to know what's important to them. So often those meetings are very much about what does this patient need for us to get them where they want to be.
Yeah, and also I think what's important within stroke as well, like other areas, we're audited, and the new guidance that came out last year has significantly increased the intensity of therapy that people should get on a daily basis. We're not given any extra resources or extra money to be able to achieve them ideas, what they expect us to do. So we're having to be really resourceful and look at how can we work differently, how can we work better as a team, what can we be doing to patients to enable them somewhat self-managed conditions around our therapy visits. And I think that's a big important part of people's journeys as well, because we don't want people to become somewhat reliant on us going in when we can't go in forever. So it's enabling them to take control of their condition, know what helps, what works for them, what we can be doing to support them with that, what do we actually need to do for them. And it's a big picture, isn't it?
Yeah, and working with families as well. So especially sort of with some of the OT speech work we do, even if it's just little games that they can play or exercises they can do, which and often they're more likely to engage with family members. So having their support as well can be invaluable.
Yeah,
I've seen some fantastic videos that you do and different things that you're interacting with patients, and that's just amazing. Is that one of the most rewarding part then of the job, where you can see people how their even small movements make a massive difference?
Yeah, I mean, when I reflect back to first working in stroke, I felt out my depth, my comfort zone, because if you're presented with somebody that has got no movement down one side of their body, can't sit up, can't toilet themselves, can't understand anything that's being said to them. Sorry. They've got problems with their vision, they're not understanding what's being said, they can't communicate with you cognitively, they're not able to follow instructions. And when you're faced with that, I used to think, where on earth do I start with these people? Now, much further down the line, you get people that are in such an awful position. We provide the therapy as a team, and the outcomes, it can be something so insignificant to us but means the world. Something as simple as being able to use a nurse call buzzer on a ward setting to be able to indicate to staff that somebody needs the toilet. That might be something very little in that person's journey but mean the world to them. Whereas there's other people that have come on leaps and bounds, whereas they're able to stand up, getting themselves out of bed, transfer to the chair with minimal supervision. So people's journeys are very different, people's goals are very different, and I think everybody gets such huge reward no matter what that impairment and improvement has been across their pathway and journey.
Yeah, I think for me, obviously, if we're supporting with the communication and we're able to facilitate them communicating with family again and able to sort of, even if it's not back to where they were before, at least being able to, tell a family member they love them, or even being able to name family members. That we often will do that in therapy with family photos, pets, places, making it very much about them and their experiences. So it's very, tangible, relevant to them rather than arbitrary photo cards that we've probably had in the cupboard for 20 years. So we really try to make it very, very sort of patient, family focused. And then the other thing is the eating and drinking. They might arrive over here, they might be nil by mouth with an NG feed, and by the time they're out, we've and again, it might be a part of our job that people don't necessarily are not necessarily aware of, but we, swallow rehab, getting people eating and drinking again. And they might arrive, like I say, nil by mouth, NG fed, and by the time they leave, they might be on normal diet, normal fluids, or at least being able to maintain their nutrition by eating. And if you think about nutrition, if you think about eating and what a massive part that plays in social life, you pop and see someone and you have a cup of tea, or you all plan to go out for dinner somewhere, that means they can be part of that again, and that's huge for them as well.
I know we've discussed this before, because I say as a speech and language therapist, you just think, or people think, that you only deal with people's talking and their output of speech, whereas actually within stroke the swallow part is such a huge part of your role, isn't it? And I think other areas, if you haven't worked in an area where you have a speech therapist as part of the team, I don't think people have a good understanding of the swallow part of your job.
No, and that is we're doing a lot of training around that awareness now of those difficulties, because also if we have a patient with swallowing problems and they are an aspiration risk and they are, they do have something that isn't safe for them, if they end up with a chest infection, it will put their rehab back. So the work we're doing, the work OT, physio, etc. are doing, it might be that we get a week or two where they're just not able to engage because they're really poorly with a chest infection. So we're doing a lot of work around swallow awareness, and actually, again, because it's not as tangible as seeing somebody's, they can't move that leg, we're not going to get them to stand on it, but the swallow is so what's the word,
it's like a hidden,
you can't see it as much. So it's basically based on our assessment and saying, please don't give this patient a biscuit because it could potentially cause kill them. Honestly,
well, that's it. That's as
I was trying to say that sensitively, but basically, that could be it.
That's as serious as what you're dealing with,
Yeah.
isn't it? And that's why you've got to make those decisions, and that's why you work in the way you work to make sure that is communicated to people who don't have the skills that you have, to make sure our patients are safe. So absolutely.
And I think that's when I go back to when I said earlier about often people when they're in hospital are somewhat medically stable for a lot longer than what they are therapy fit, because when we work with people in a hospital setting, we work with them to be able to get home or their next stage from hospital. But when they're at home, it's where the therapy is very much around the person, the environment, their everything about them, so the family, what what do you want out of therapy? You're at home now, you can stand up for short periods, what do you want to do? We could go in and say we want you to walk, we used to do that, but that might not be important to them. So I think when people are home, it's much more personalised to them and their surroundings. And the fact that therapists support people to get home sooner, you know, it prevents all the hospital acquired infections. We have such a positive impact on the length of stay as well, don't we? So that we get, because they're waiting on us to make sure that the therapy fit or safe to go to another environment, we are the important part of that puzzle, aren't we? I think often AHPs, whether it be a physio, speech therapist, occupational therapist, dietitian, often get overlooked in some of the discharge process because the medically fit get them gone.
Yeah.
We need the bed. It doesn't work like that. If somebody's unable to do anything for themselves, we need to facilitate that.
And I think that's where we're really lucky with Kirsty, our consultant, because we can have those open conversations and say, you know, because my team are across the pathway, I will get a phone call from my amazing Becca on 1234 to say, not sure about this, what do you think? And we have, you know, we can have really good discussions about absolutely get them over here because, you know, we can support them. Or actually, that sounds like we could get them home straight away, don't need to come here, and we can get ESD in straight away to support. It does feel like a very effective team as far as communication and working together with the patient very much at the centre of what we're doing.
And I think all of that supports timely discharges, because I think for me, looking at our community service, our early support ESD team, if it wasn't for them, I think some people would be reluctant to discharge people, particularly those with like hidden problems. So if somebody's physically unimpaired, so they can walk and move all the limbs as they normally had, but cognitively they've been impaired or they've got speech impairment, knowing that they are going to get appropriate follow-up from a community team is somewhat relief for the therapists on the ward, because they do care about the patients. They don't want people to go home and struggle, and they know that they're going to get follow-up for whatever it might be that they're having difficulty with. And I think having that team there is reassurance, and it's part of like our guidance into what we should be doing, but it does support discharges having that in place.
Yeah, and I think we probably need to, along with this podcast, do other bits to raise that profile and raise that awareness of how important the teams are, because working from a very acute trust, and you have as well, Jen, we don't always see that. So it's really good to hear what you're saying, and maybe we need to do more things definitely around how we promote that, to know that we're all one big team, and what good skills we have with our AHPs colleagues in the community areas.
Can I ask, what made you choose the community setting over your acute kind of colleagues?
I've worked across the full pathway. So my background is stroke. So I've worked on an acute ward. I've worked for probably about 9 years in a community setting. And I feel like here at Redcar, for me, is the best of both worlds, because we've got a community hospital with a ward. So it's still a ward-based environment, but it's a community hospital. And then we've got the community team. For me, when you work on an acute ward, people quite often at that stage are acutely unwell. From a stroke point of view, quite often they've got lots of things going on medically. They're really quite flat, so they sleep a lot. They're not alert. So in terms of rehabilitation, sometimes that can be a bit more limited. Whereas when you move to a rehab setting, such as a rehab ward here or a community team, I feel like it's when you get your teeth into people, you really get to know them, what they like, what they don't like, what can we do to support you on your journey. And I personally, I'd happily go on an acute ward again if I had to, but for me, I think my passion sits in the community.
Yeah, I'm the same. So I've been here a year now, but I worked on the Isle of Wight as the community lead for the, and it was, my background isn't stroke, I'm a generalist, but I did a lot of the neuro work and the palliative work down there. And obviously the Isle of Wight is a beautiful place to drive around all day. So that's probably why I quite enjoyed the community. But I think equally, you know, thinking about the patients that you meet and the chances are you're going to be part of their lives for a long time, you know, depending on what their diagnosis is. So going out, seeing the family, meeting, you know, their friends are visiting or their children are visiting. And for me, that I just really enjoy that aspect. I do still work on the acute wards here, but certainly community is where I like to be.
I can definitely hear the passion that you have, for both of your roles individually, but actually for the fact that you work so closely together. That's really coming across the importance of that MDT approach. And I think that's really unique to teams like this, where you understand that your role, like as an OT or as a dietitian or as a speech and language therapist or as a physio, important, but actually together as a team, you're far, far stronger for the patient.
Both of our roles were empty, weren't they? They were vacant for a while, and then I started in August, and then there was the promise of Marie, who started later. And I think because we've both come into it new with no sort of previous ties, I think it's worked really well because we've been able to come in with sort of fresh eyes, fresh look at it, and we do have very similar outlooks on how our patient journey should look and how things should work. And I think it's meant that, and hopefully that's sort of filtered down to the rest of the team, that the communication and the way we work is key. It helps that it's a fantastic team. We've got amazing staff.
I don't think although we've got an idea of how things should look, we're not precious about things, and we're very open to ideas. That although we do our clinical hours, we're not the people that are always on the ground seeing people. So we're always asking, what do you think we could be doing differently? What would be better for the patients? What should we be doing to improve things? What could we do differently? We're not opposed to any changes, and I think people are open to bringing ideas forward, trying new things.
I think also we need to mention the ward and the nursing staff, because again, I think with us being in post and the work we've been doing, it does feel much more like the Zetland team. So it's not the nursing staff, the therapy staff. We're working closely together. We're trying to sort of have training together and do things together. And I think that's a positive as well.
Yeah, going back to your question, saying about how important it is as a MDT. It is, because I know, although we've been upskilled, and I know what speech therapists do. I'm not a speech therapist, but if I was seeing a patient and we didn't have a speech therapist in that day, I know what I could do as part of my therapy to approach both aspects. And I think we were all very good at knowing your boundaries, but working across your boundaries to some degree. And I would go as far as to say I couldn't do my job without the other professions. We all are as important as the other. Even, for example, dietitians, when we have people that can't swallow and they've got an upper limb deficit and a cognitive impairment, as a team, we would look at physically if they're going to have a peg fitted, cognitively, do they understand that? From a dietitian point of view, is their nutrition maintained? So we've even been discussing recently about getting a dummy that we can demonstrate to patients in practice, so that they know whether they get a peg, that they're going to manage it, and they get the full concept of it. So that's a perfect example where something so little has happened. Well, it's not little, but for part of people's journey, having a peg fitted for their nutrition, actually there's a bigger picture and everybody's involved in that, aren't there?
Yeah. So we're going to come to the end of our podcast now, because we've obviously got busy lives and busy days. So what is the one thing would you like to say to either our listeners or anyone who wants to come into being an OT? What bit of advice would you give people about OT or speech and language therapy, or coming into work in industry?
From an occupational therapy point of view, to advocate, I think we're the best. I can say that. Team Green. We all, each profession within stroke is as important as the next person. But I think for me, for occupational therapy, we are such an important part of people's journeys. We look at I often think we're almost the glue that keeps people together, because you look at the cognition, but for you look at the communication from a speech point of view, but for the communication, you need to know the cognition. For somebody to understand instructions about physio, they need to understand what's being said to them, which is part of that, of speech therapy, but also their cognition again. And we all interact with one another, and I feel like from an OT point of view, we do all the little bits that often get unnoticed. And with stroke, it is like my true passion. So I would absolutely encourage anybody to come and either shadow us, message us anytime. We would happily have anybody come shadow us. It's such a complex area, but actually it can be daunting, but it's so rewarding, isn't it?
Yeah, you can make such a big difference. And I think even if you're not getting those people back to eating and drinking, or you're not getting them back to the communication they did before, the other work we're doing to support and offer strategies as best we can, you know, we can get such good outcomes, and you make a massive difference. We make a massive difference, don't we?
Yeah.
To them, and I think also for families, knowing that team is there. Or
I think feedback from patients and families speaks volumes.
I'll be honest with you, listening to you talking about like what you do with the patients and how integrated into their lives that you've become. I'm getting a bit emotional just listening to you, so I can't imagine how you kind of feel on a day-to-day basis with them patients that you spend so much time with. And I think, do you know what? It's been an absolute privilege to spend some time just listening to a small bite of what you do. And it's really opened my eyes, and I really do appreciate the time that you've spent with us.
Yeah, it's been really nice because I'm from an oncology background, and it's really nice to hear your passion about stroke, because I feel the same when I work clinically. And I think it's an area that I don't know much about, so I would very much like to come and shadow you. And I think we should probably do some more promotion work in the future about different projects you're working on and things like that.
You're welcome anytime. Thank you so much
for having us.
Yeah, thank you.
So I want to say thank you for listening again this time. Look after each other.
And yourself.